Functioning and Quality Committee. My name is Judith Hardesty, and I have recently just taken over the chairing of this meeting. So bear with me if I make a few errors, but I'll try and keep us all on track. I've got a few people to welcome and a few apologies. But if I can start by saying to everyone who's presenting that everyone has read the papers. So when you are presenting, can you please just highlight any key issues? If there are any corrections to be made, obviously to draw those to our attention, and any updates which have occurred since the papers have been published. So thank you very much. So I'll welcome and introductions. So I'd like to welcome Charlotte Middlemas, who is joining us online, who is the Interim Deputy Director of Workforce Transformation. And Charlotte is here to cover for Lisa Llewellyn, our Executive Director of Nursing, Health Professions and Quality. Welcome, Charlotte. I'd also like to welcome Dawn Bratcher. Hello, Dawn, who is Assistant Director, Strategic Partnership, Engagement and Insights. That's a snappy title. And you're in attendance to observe the meeting, so I hope it will be worthwhile for you. And finally, I'd like to welcome Sue Stowe, who is the Associate Dean for Improvement and Innovation, but today is here to represent Kirsty Moons, our Postgraduate Dental Dean. Got that the right way round?
Yeah, I'm the Dental Quality Lead.
Right, thank you very much. And also I'd like to welcome Anton Soman, our Acting Medical Director, who is that right?
Interim Postgraduate
Dean. Sorry, Anton, who is also joining us on Teams today. So welcome. Right, I think I can safely move on to apologies. So we've had apologies from Lisa Llewellyn, Executive Director of Nursing, and Kirsty Moons, Postgraduate Dental Dean. Before we make a start on the agenda, I just want to give people some notice that I am going to move items around a little bit on the agenda. After we've dealt with item 3.1.1 on medicine, I'm then, before we move on to dentistry, pharmacy, optometry and nursing, I'm going to take us to the General Medical Council Training Survey, which is item 3.2.2, because there's a real link between the two papers. So I'll remind you when we come to it, so that's why we'll take a pause when we finish the paper on medicine. Okay, so any other apologies that I haven't noticed? No? Okay, and are there any declarations of interest on any of the items on the agenda that we need to note? No. Okay, thank you very much. So we'll move on to the consent agenda 2.1, and we have there the minutes of the committee held on the 17th of July, and I've not been noted of any items to come up under there, but I'd like to ask if anyone has any corrections to make on the minutes, which go from page 1 to page 9. Anything to amend? No? Okay, thank you. So are you content to accept those as correct record?
Yes.
Yes. Very much. And then we have the action log from that meeting. Is there anything there which anyone wants to raise? No? Okay, thank you. So we'll note the action log, and thank you for all the updates that have been provided as part of that. Now, are there any other items to raise from the minutes from the 17th of July which were not captured on the agenda? No? Okay, thank you very much. So we will move straight into the first part of part 3, which is 3.1.1. Tom, is there anything you want to say as introduction?
Thank you. A couple of things I'll introduce in Welsh if I may. Tom, diolch yn fawr iawn, Gadeirydd. Diolch yn fawr iawn, Gadeirydd. Mae'n bleser cyflwyno'r 4 papur gan y gyfarwyddiaeth feddygol. Gai ail bwysleisio i fy cydweithwyr bod y papurau wedi cael ei ddarllen yn fanwl, felly dim ond y prif bwyntio sydd ehangach. I'n cychwyn i gai ofyn i Anton Seaman roi'r wybodaeth ddiweddara i ni gan yr adran feddygol. Anton, if you wouldn't mind giving us the update for the medical team.
Thank you very much, Tom, and thank you very much, Chair, for facilitating me to do this on Teams. Can you hear me okay?
Yes.
Thank you. I will aim to be brief, and thank you for taking these 2 items back to back, because there's considerable overlap. I know that you have all, as always, read the papers with interest, and I will just give some very brief updates around the medical deanery quality update for assurance. And I'll just mention right at the start that there are still 4 areas that remain with GMC enhanced monitoring, and they are as listed, and that is not unusual, and that the process of enhanced monitoring often takes quite a long time, usually a minimum of 18 months, moving on to longer periods of time, as the regulator requires quite a lot of assurance. Recruitment has been good this year. We have done a large number of ARCPs with a large number of panels, and I've previously said at this committee that that workload is ever increasing, but we are grateful for the residents that we can train. I've given a little update around our appraisal of those teams of people that deliver training for us within the health board settings. They are really important because they are, as we like to say, on the ground, close to where the training takes place, and we help those teams to improve. You will note that there's been 9 new targeted visits between May and July. We don't do many targeted visits in August. These visits were in progress, and I must make it clear that none of these visits were triggered by findings only related to the NTS and have been already in progress, but these visits has been triangulated with some of the things that came out of the NTS, and those 9 were emergency medicine in Wrexham, which was visited on the 10th of July, medicine in Glangwili on the 16th of June, gastroenterology at UHW on the 18th of June, cardiothoracic surgery on the 19th of June, medicine in Nirenbemen on the 25th of June, general medicine on the 30th of June, pediatrics on the 9th of July, TNO on the 16th of July, and cardiology on the last day on the 31st of July. Of this reporting period. For brevity, we haven't included all of those details. We then have a list of the high-risk concerns where we often ask for a proportionate response, in other words, local updates on risks that may be increasing before we would necessarily trigger any kind of escalation. I have put in some very important CPD and quality improvement activity, which I haven't put in before, which has been undertaken by our colleagues from the GP section and the RSU, which is good. And I draw your attention to the GMC State of Medical Education and Practice report, which is available online, and highlights issues related to staffing, leadership, equipment, etc. A large proportion of what is in this report will necessarily overlap with our immediate findings and emerging themes from the NTS, but I think I'll stop here and give some opportunity for questions, Judith, if that's okay. Thank you.
Yes, of course. Thank you very much, Anton. Okay, I'll open it up to questions then.
Yeah, a couple. And thank you for the update, Anton. Just in terms of recruitment, obviously the foundation programme, you know where we were at the position at the beginning of August, and we had 16 vacancies, and you split it by health board. I've just noticed, obviously, you know, one of the health boards seemed to have a lot more than the others. Any updates at all on any of that at this stage?
Yes, Donna, we've had this and we've discussed this before, and we are all familiar and aware of the pros and cons of preferenced informed allocation. This year, we opted to give our residents the opportunity to be allocated earlier in the cycle than usual. We think that that was fair and proportionate, and therefore all residents were offered a day on the 16th. On the 16th of June, were offered a placement. Some residents asked to wait a little longer in order to see if other places became available that would meet their needs better. And what that has resulted in is that we have ended up with vacancies around Wales, but we know that Hywel Dda has been disproportionately affected, as has been the case in the past. Those posts have been handed back for local recruitment, and I believe that that local recruitment is going well, maybe from a pool of doctors who were previous foundation doctors within Hywel Dda. Thank you.
Tom, do you want to comment on that?
Is that okay?
Yes,
If I
of
just
course,
add a
yeah.
little bit to that question. Anton's right, he's just explained the challenge that we have in foundation with being oversubscribed at the point of allocation, but then the attrition that happens, the vacancies, the disproportionate distribution, as you just asked. Historically, we know that Hywel Dda, and particularly its regions of Hywel Dda, so it tends to be Bronglais and Aberystwyth, which gets worst in those areas, and there is a historical pattern there. We are doing work because of that risk with them locally. And interestingly, this year, a number of doctors who did foundation in Aberystwyth last year who didn't actually choose necessarily to be there, they've had a really good experience. And actually those people have chosen, after completing foundation, to stay in Bronglais as locally employed doctors for a year or two. So our training funding still supports that area. So although the vacancies are there, I just wanted the committee to be aware that we continue to work closely with them to mitigate the impact of those vacancies.
I mean, that's what I was asking, wanting to know how to mitigate, but that's very helpful. Thank you, Tom.
Okay, thank you.
Sorry, I've got one of
Yes, okay.
It was just the GMC State of Medical Education and Practice report, and absolutely there's the link. But I did notice that while it says we're broadly in line with the UK average, there were those areas where there was some concern, particularly around barriers to patient care, which included inadequate staffing and organisational leadership. And I know we take all of these things and triangulate it in what we're doing, but is there anything specific that we should be cognizant of and that we need to be doing more of in terms of responding to that, Anton?
Yeah, thank you, Donna. That's a very good question. I think workload and staffing is something which comes up in multiple in multiple places and multiple fora, and this is something that we discuss with our health board partners regularly. We will see when we talk about the NTS survey results that we can also extrapolate into there that a lot of comments, both free text and in the survey, is related to workload and the effect that and rota planning then has staffing, as well as maybe reporting issues around workload, which we are working on with our health board colleagues continuously. So I think those things is not out of the blue or a surprise, I think, but it is things that we are working with in the challenging landscape, which I think I would be brave enough to say is the same across Wales and the United Kingdom. Thanks, Donna.
Okay, thank you.
Okay, right. Did you want to come in on that?
Is that,
Tom?
well,
It's
yes,
fine,
it's an interesting, it is an interesting question, and it reflects partly about your question is about our function as an organisation, but also our partnership function with other organisations in Wales, because a lot of this paper reflects the whole system issues. And it's probably just worth noting it actually links very well and is feeding into what the Ministerial Advisory Group published, a lot of which was about the development of clinical and medical leadership and using that as part of the transformation services in Wales. We are part of that group influencing the clinical and medical leadership led by the Chief Medical Officer, Chief Nursing Officer. So this intelligence is all part of that All Wales group, which we'll have to report. Because clearly, as an organisation, we have that statutory national responsibility around leadership development, which is in terms of governance, that is dictated by that the Culture and Leadership Board, which the Director General chairs. So there will be a lot of themes relevant to that will emerge in terms of recommendations, which may influence our direction of travel in the future.
Thank you.
Thanks. Any more questions? I've got a couple, Anton. Sort of one of them relates to the situation. This is part of the enhanced monitoring section in Anira and Bevan. I know I've raised this before, but I just get a bit concerned when we don't have a possible end date. And, considering clearly we know about the recruitment position, it doesn't seem to be affecting the take-up of roles there and posts there. But if we have this continuing issue of the experience, I just wonder, I know it's a GMC process, but at what stage are we, how many more visit years are you able to say? I've got another question, but I'll leave that one first.
It's a good question, Judith, and I'm very mindful that you've asked it before and we've raised it with the GMC as well. And so you're right, this is a GMC-led process together with us. We visited together with the GMC the 25th of June to Anira and Bevan. And although there was work in progress to address some of the trainer capacity and access to clinics, there was a ask for a revised action plan and another visit to be arranged. It's very difficult to say exactly when this is going to be concluded and what day enhanced monitoring will end. But we will bring progress back to this committee. We discuss this with the GMC at regular intervals. And of course, the Health Board is working hard to as well to work towards the recommendations that we've put in place. Thank you.
Okay, I suppose I accept that. I understand the process. It just does seem a real outlier because we have other health boards coming in and out with different specialties, and the monetary status changes, and we've had this here for 3 years, and it feels a long time to be in that position with one of our largest health boards. But I accept the answer. Tom, do you need to add to that?
Yeah, no, I think there's definitely progress. I think there's a slight difference about the enhanced monitoring status of this compared to some of the others, which are departmental focused. This is across the health board and related to the complexity of introducing a new hospital and a new service delivery model during a very challenging time, in the early years of the pandemic. And you are quite right, they're very engaged as a health board. There's really good progress. Their risk rating from our perspective is actually slightly lower than other areas, which is the slightly ironic thing in the question you're asking. But when it comes to the GMC oversight, what they're really keen to ensure is that in addressing the concerns trainees had initially, that what you don't do is shift the problems elsewhere. And one of the challenges that we've had is there's been a major improvement in the initial issues that triggered the enhanced monitoring status significantly have improved. As Anton has said, there has been a slight change in some of the experiences, but those in themselves of the trainees, those in themselves probably wouldn't have been things to trigger enhanced monitoring in the first place. One of the key issues that's being addressed is the fact that the burden that resulted on the trainers in addressing some of those issues. And one of the GMC key standards is ensuring that appropriate support for trainers is also addressed. So there are many trainers in there who've been identified as taking responsibility for overseeing far more trainees than perhaps they should. And given that in the reports we've talked about the burnout rates of trainees, the GMC are slightly very keen, understandably, to see measures in place, but that is being addressed. So I am confident we're on the home stretch. I'm bold enough to say that, but we do not set the date. The GMC do set that, and I understand your frustration on the question. But I think the way it moves from one place to another, and that complex service model, is why this is slightly different from perhaps other enhanced monitoring things that you see.
Okay, thank you. Because Don has covered some of the areas I wanted to ask, but my final point is when I look at the appendix, which is I always find very helpful, but basically, and I think I was correct, that every single health board in Wales has got issues somewhere. I don't know if that position, because I've not been here long, but whether that position is expected, because they are across a range of different specialties, I understand that. But I just was concerned, I suppose, looking for assurance that these issues that are being flagged around training, experience and quality, would we expect every single health board to be in that position of escalation?
Thank you very much, Judith. Again, a most excellent question. So these are I think you're referring to the escalating concerns, which is in the appendix. So it is not unusual at all for me to have concerns in every health board. These concerns come in for a number of reasons, and they're at very varying levels of concern. So we have low, moderate, high risk concerns. Almost every concern will have a proportionate response of a local investigation first to see what the nature of the concern is, whether it can be dealt with locally. An action plan will be requested. The health board will put an action in place, and they may say a few weeks or a month later, you know what, this concern about access to a clinic has been closed, we've done it, it's sorted, and we move on. If we do not get the appropriate response or assurance from an action plan on what needs to happen next, we will escalate that concern and may trigger a targeted visit. So it's not unusual at this point for me to have a lot of concerns that requires local investigation, action plans. Can they be closed? Or do they need to be escalated? And there is, in my tenure here, Judith, I think every health board, except for Lindra once, have always had some concerns. Thank you.
Thank you. Finally, the point that Donna raised about the GMC ratings, and particularly the issue around I'm trying to find it on my page now. Sorry, I will find it. The issue about the organisational leadership, which is a higher level of dissatisfaction in Wales. I'm seeing that coming out in some of the targeted visits about organisational leadership. I suppose it depends on what you classify in that, but does that become a focus of discussions? Because it's linked to the trainer's time, I understand that, but generally leadership for the organisation.
In terms of the quality management and escalation process for our training programs, we're very focused on the experience that our residents are getting. We're also very focused on issues where patient safety might be an issue, and that gets escalated immediately. Where the way training leadership is enacted impacts on the training environment or things that we pick up, we will feed that back through the training process. But if it's significant, we will feed it back as well through senior structures, AMDs and MDs if required. Within the training environment, I think we do have to be mindful of our remit, which is around the training of doctors, but we do highlight issues where we feel leadership is required, and we've got avenues for doing that, Judith, in all sorts of places. I hope that helps. Ta.
Yes, thank you. And then I will end on a positive, because this is about us taking assurance. And I was really pleasant. Well, it was great to see that 96% of our GP trainees are satisfied, which, considering the direction of travel with developing primary care, I think that is a very good outcome to have that level of trainee satisfaction. So I think we should particularly note that as being positive. Okay, well, if there aren't any more questions on this paper, can I ask everybody to note the contents, and which provides us with an update on the quality of postgraduate medical training for the purpose of assurance. Intent to do that? Thank you. Right, now we'll have to scroll a bit faster on our systems now, because I want to move us down to 3.2 on the agenda, which is 3.2.2, which is the GMC National Trainee Survey. So, Tom, are you going to introduce this while I quickly find it?
Yeah, I'll very quickly introduce. I mean, the training survey, I mean, it's the GMC's national training survey. It's done every year. It's a huge exercise, which provides a lot of rich data for us. It is important to remember, following on from the point Anton's just made, it's one source of data which gives us sort of statistical quartiles, really, rather than necessarily some specific all the specifics, but we do get pre-test comments. So it's part of our continuous improvement approach, and it is one data source, but it is really helpful in terms of points, identifying where we're at and where we're directing our focus. So I'll let Anton come in with any of the headlines, because obviously what we do at this stage is identify themes that are emerging, which links to your earlier point, Chair. And I'll let Anton just run through those briefly and open up this discussion.
Thank you very much, both. As Thomas pointed out, the GMC National Trainee and Trainer surveys are really important sources of information. They are not the only source of information that we have, and we would not, I'm going to say in a public meeting, ever institute a targeted visit solely on the evidence that comes out of a survey. So it is part of the important information that we gather, but we will always triangulate all information. Having said that, there is also a vast amount of information with hundreds and thousands of data points. The highlights is that most of our residents are either satisfied or very satisfied with their training. And we compare well with other deaneries in the UK, and I'm going to say that some of the people that have better results are small organisations. Wales consistently also has the highest response rate in the UK for both trainees and trainers. I have to say that response rate is coming down a bit, which might show some of the fatigue that residents are experiencing around being asked questions in multiple ways continuously. There is some UK data included in that, which I present with trepidation, because I can't really comment on the whole UK data, because the GMC has data that we do not have access to. I just want to point out to the committee that residents have the opportunity to put free text comments into the survey if there are things that particularly concern them, and those free text comments are dealt with at the time that they are received. They do not wait until the end of the survey. Action plans for those are put in place immediately, and those have all been resolved, actioned, or built into the regular reporting and the quality management process. I can assure you of that. There has been several areas of good practice identified across the training programs, which we have noted. We have explained what we have done with the results, the summary results, and where they have gone. Trainers is always something that I'm keen to mention, and I really just wanted to draw your attention to the fact that a lot of trainers really love the job, and a lot of trainers really get burnt out by the job, we have got agreements in place for trainer time. The more than half the trainers have the time allocated to do their training, but it often gets encroached in by other things, for example, clinical work, which is understandable in the environment that we are, but is stressful. The emerging themes are there. I said that overall satisfaction is good, reporting system are improving. Workload is high. We have some work to do on regional teaching, and this is in part an issue of the geography of Wales, and also in part an issue of rotations and other things that we have to look at, and we are well aware of that. Less than full-time trends are increasing as always, and we're increasing a little bit faster than the rest of Wales. Medicine and unscheduled care in Wales, the UK, and probably the world is under immense pressure, and has been. And I will end by saying that we've looked across directorates at the National Students Survey, which is another really helpful piece of information for HEIW. We can't draw any parallels at this time with medicine, but we will keep on looking. I'm very happy to take any questions. Thank you very much.
Thank you. Thank you very much, Anton, for that and for the papers. Any questions?
I think mine is sort of always looking at sort of the surveys and how they drive visible sort of practical change. So I suppose for me is sort of the next steps, is taking the next steps, and what are the immediate changes that are being prioritised to, you know, in response to what trainees witnessed this year? And I think for me, I'm looking at that short-term improvements and identified and in progress, so we can track what's going on.
Is that for me?
Yeah.
Okay. Thank you. So, as I said, the immediate things that come up right in the beginning of the survey would usually be the free text comments, and those are communicated and acted on immediately, and they are often issues related to workflow, patient workload, etc., and we notify the health boards of those immediately. The immediate issues are slightly different in different health boards, different programs, and different learning environments. So we have to look at they're not exactly the same in every place. So we look at them and feed all the issues that we've identified back to the health boards immediately, and then ask them for an action plan of what's going to happen next. But if it feeds into something that we are already concerned about, we may triangulate that, arrange a targeted visit, and go there to go and see. So all those processes are currently in progress. I hope that answers the question, Tom.
It does, I suppose, from a sort of feedback and assurance back to this committee. I just wonder what that timeline and how it looks.
So can I briefly come in? Thank you. I mean, this hundreds of thousands of bits of database. So the first bit is the immediate things that need to be done. Actually, it's quite unusual for things to emerge in the GMC training survey that we've not already cited on. It can happen when we look at that because things can change so quickly, and those are active in the way Anton said. Then you've got the themes, which are really important for us as an organisation, and what are the recurring themes, and they may be regional or national. So, for example, some of the things that come out there will drive or ongoing bits of work. So the increasing trends, which are disproportionately greater for us in less than full-time working, is having a major impact on service delivery. So we are then triggering a little bit of work to review, get that data, work with health boards about what that means, how we do that. That will be work that will continue on an ongoing basis, and this will give us markers. The immediate quality things, the processes are really tight for escalating in. They've all been shared straight away. But it's actually more about the continuous improvement themes that emerge, and probably a bigger value out of that thing that comes out of this data source.
Okay.
Yeah, I've got a couple of questions, Chair, and the first one is actually on the back of the discussion we've just had, really, but agree with Dawn in respect to what we do. And I know this, you know, we won't necessarily go back to individuals on the free text that they've done, but as part of that feedback loop, do we ever do a kind of, you know, globally you've said, and this is what we've done sort of response? Because hearing Anton say that maybe people are, you know, on sort of survey fatigue, if they aren't seeing that changes happen as a result of completing them, then they may be less inclined to complete. But if they actually do see that taken on board, it might be valuable. So that's kind of a comment more than a question. I know too. And then one of the others was just in the paper, you note that a summary of the concerns go to the health boards through the assistant medical directors or the equivalent, and copies to the chief execs. Do we know what they do with it? Do they have that? Are their boards cited on it? Are there actions put in place that they're responsible for doing it? So I'll ask that one and then let somebody respond, I think, before anything else.
Yes, absolutely, Donna. So where we write to the health boards, you are right. The escalation procedure for medical education quality issues with it varies from health board to health board, but it is invariably related to the assistant director for medical education or the DME via the medical director, sometimes also to OD committees, and then that direction to the board. When we send these letters about the issues that we have aired within a health board, we state them and we request an action plan, and we follow that action plan up and within usually about 60 days. And we get acknowledgement that it's been received. We ask for a local action plan. We scrutinize that local action plan and then usually have a meeting locally with the education team in that health board, and they would escalate the concerns that we've raised via the assistant medical director, and that way to their board. And this happens for every health board that we write to.
Just picking up, I think, Donna's other point, how do we know that is happening, that escalation where needed? And should we know, I suppose?
Well, we should, we do. And I think what you beautifully described in your question is a quality management system, the whole bit about data that changes what we do, you know, our planning arrangements, then there's the data, all the different bits of that, and then the overarching governance and scientific. So we definitely escalate to that level in the board. It's timely because we're in the middle of our annual review of what that leadership structure looks like, chaired by our chief exec, with each health board and their executive team, and accountability and visibility of these issues at board level is part of the feedback we require as part of that commissioning annual meeting. And that process has been extended, although it's there for medicine, it's been extended across all our professional areas to ensure there's that board level visibility, accountability and action.
Right, that's really helpful to have that confirmed. Thank you. Just a couple from me. Have we had conversations with the GMC about the ability to access Wales data? And what's been the response if we have?
Yes.
So for the National Trainee and Trainer Survey, we can access all the data, Judith. So there's a reporting tool. So we have access to all the data, and we interrogate that data, and all deaneries, and it's public data now, and all deaneries have access to all the data. It's just the whole UK summary that's at the top of the report, that the GMC included some data which was from other sources that we didn't have access to. But in terms of the trainee and trainer survey, we've got access to the individual question data, sites, posts, by deanery, by area, by program. So this is why I said there are so many different data points, and we have interrogated a large number of them and will still be interrogating some. Thank you.
Okay, I think I got a bit confused then, because I read some of this as if we didn't have Wales specific data, but we do.
We do, and
Right.
we have access to the broader GMC's data.
Okay.
What we are doing and work that Craig is involved with, and we've met with the GMC a few times, is clearly as a statutory body with a workforce intelligence function.
Yes.
We have a lot of data ourselves already, and then there are other data sources that can inform or support that. So we are in the process of working with them to actually develop a more robust system for our own data ownership and how we access it from the GMC. So we have ongoing partnership working with them to really develop that.
And just to extend that, and I'm now looking at you, Craig, does that mean we can also then look at the data that comes from the other survey we'll talk about later, and the other quality data we to triangulate that for other professions? Because what I'm thinking about, this is really for next stages. So if I look at a comment that's in here about obstetrics, and there's a comment here about being hesitant to escalate concerns in a number of specialties. Obstetrics is one. We know there've been issues. We know there's going to be a Wales-wide review, whatever inquiry or whatever it is going to be into maternity services, and we've had feedback from midwives around their training. So are you looking to be able to pull all that together so you could say, right, that specialty in there are issues from?
So we are looking to pull things together, and we've built quite a bit of infrastructure. Technology is not the problem these days, it's more the processes and the data acquisition and the quality of the data.
Okay.
So whilst I think I've reported previously that for some of the non-survey data, we're linking that on a person basis, and then there's standards and reference standards around that, i.e. if you've got a site, you need to make sure that it's consistently named the same thing, but it would be coded, and then you've got all the reference data sorted. So an apple is an apple, an orange is an orange, and we're not mixing that fruit together in one basket. Just to explain it maybe more simply. So we're looking at all the data standards and ingestion of the data. We have got a new way of looking at survey data. So by way of example, we're pulling in some of the GMC stuff, but we're also pulling in the NHS staff survey data as well. Now the challenge has been the way some of it's recorded in those back-end systems to link it and relate it together, which is back to the apples, bananas and pears piece again. So we are working towards that, and where it's part of the same piece almost in terms of the awareness to retirement person linkage piece. But survey data is maybe is a little bit different, a little bit nuanced.
Timing, when, because I think this would be a really good topic, I have to say, for board development at some stage, and then reports will come through to the committee. But what's realistic in terms of being able to have a, for me to be able to say, right, Anton's highlighted issues, say at CUTAF over maternity, about culture. So we could look and say, right, well, what are the midwives saying, what are the nurses, what are the physios, radio, when that's my simplistic, when are we going to have a fruit roll?
So I think
that isn't a mess.
I mean, it's probably worth flagging at that point, because it'll come up when we discuss the NSS. I think it's worth reminding the principles of what you've just said are exactly where we're aiming for in terms of what our function is, triangulating the data sources, not being so focused on narrow single specialty processes that we don't look wider when there are broader national signals emerging. And we are using the obstetric and the maternity neonate experience to influence that. But it is also worth remembering that our function in our commission programme for those other healthcare professions is very different from what it is in postgrad medicine. So the universities are responsible for collecting data, and the data they get from clinical placements is often very limited and very much later than their placements, and often a snapshot. So what we found in looking at the various issues that have arisen recently is that actually you're quite limited and unlikely to have many things that actually do it, but you've still got to look and you've got to know when to dig a bit deeper. data is really interesting and it'll be an ongoing journey of improvement, but we are definitely on that journey, and Craig is doing a good job in trying to identify where the barriers are to us getting it together.
Maybe the exact times. Oh, sorry, Chair.
No, it's fine.
It's fine. To come back in, I think maybe the exact. So we've done some stuff already. By way of obviously the staff survey, the wider NHS staff survey. We've got the GMC data in. We're also having conversations with Scotland as well, because they're hosting a secure data environment for some of this, and have got most of the GMS data in there as well for the 4 nations. So whilst I can't give you definite time frames, maybe that's an action for me to update in the next session to give you a little bit more.
I don't think it's just me. It's not just me that's interested. I think what we'd be really interested in this and how that helps us sort of in the role that we have in an organisation. I like the football analogy. I can get my head around that. So thank you. Thank you for that. Ian, you want to come in?
That's exactly Tom's point, and we will be some triangulating, but we need to be mindful of data that we're getting from individual sources. So what this will allow us to do, the kind of work that is taking place here, it'll allow us to consider whether there are any gaps and think about how that might be filled. So I think that what we are finding is that there's not a kind of straightforward compatibility between data sources, but that will lead us to be able to reflect on where the gaps might be and how that gap might be filled if it's possible to do that.
Great, thank you. I've just had a nudge that I'm in danger of overrunning, so I am going to draw this very interesting topic to a close, and I'll just find the recommendation. So we're asked to note the data that's in this paper, which I think we have done, and we've asked sufficient questions. So, and we look forward to sort of next iterations and also updates on the outcome of the action plans. So thank you very much, and thank you for allowing me to change the agenda. So now back to 3 points. Yeah, let me do that. Yes, I'm just on that. Yeah, just in the read that. Fine, thank you. So we'll go back now to 3.1.2, which is dental. So you'll have seen that. Just any highlights you want to bring out?
I told you me on the way down the stairs, so I was stick. Basically, it's the recruitment issue that I want to sort of touch on. Foundation training, we are still, all the posts are filled. And just to update you, next Tuesday we're expecting a ministerial announcement about the new NHS contract, which should give us an idea about potentially what may happen in terms of practices who have DFs. They like the contract, hopefully they will stay. We've obviously got the risk that if they choose not to continue in the NHS, it's mid-training, it's April grad trainings, which obviously you will need to do. Coming on to dental board training, unfortunately we've had several resignations of posts. So if you look at DCT, the total was 2, it's now 5. We've got at DCT1 we've got 2, at DCT2 we've got 2, and DCT3 we've got 1. And unfortunately they're all in North Wales in medicine, which is an ongoing issue. We are looking at different ways of perhaps working. We are in the process, we've got 2 pilots in Hal Var of 2 longitudinal posts. So they stay DFT, DCT1, and their DCT1 is done in primary care, but with a specialist, I think, like they're doing the wall surgery at the moment. And this is what we're thinking may attract dentists, dental trainees up into North Wales. They like the security of knowing where they're going to be for 2 years, because they apply annually and they can be moved all over. No change in specialty training, and on a positive note, the Welsh Foundation trainees have gone up from 7 to 8, so only 50%.
Okay, thank you very much. My colleague based in North Wales concerning about that. It is concerning for various services. Yeah. Okay. Thank you very much, Sue. Questions? Questions I've got. Actually, your comment about the contract has sort of overtaken one of my questions, because I just wondered where that was up to. Are you getting any intelligence about how this might be received? Because to date, it's not been a great response from dental practices.
It's not improved, unfortunately. But you know, it could happen if you look at it, and not just practices, the patients coming into the practices and saying, you know, it's that continuity of care that people value. You know, their dentist, you know, we know it's quite people like the same dentist, and if you're low need, that's what they're saying. You'll be put on the DAP and unfortunately you'll be allocated to a practice. And so that is the patients don't like it, and obviously the practice doesn't like it.
Yes. And I'm sure if any of us visited dentists, they may have had those comments from their own dentist. I think there was, I did have a question, sorry, bear with me. You've got a comment here about the undergraduate dental hygiene and commissioning. You talk about an issue raised at Bangor. Is that resolved, or is that something that is difficult to talk about today?
It is, but I think potentially it would be resolved in the future. That's about as much as I can say, but things have moved on.
Okay, it flags because we've had other issues with that university which are reflected in our papers.
And a similar issue to what we had in diagnostic radiography, which escalated, which we've now sorted. So we're nipping this one in the bud.
Okay.
Myself and Nicholas Stock got a meeting with PVC and Bangor University morning as well to follow this up. I can't say too much about it in the open board, but we are very close to a resolution.
Okay. Right, well that's good to hear. So that's good. Okay, Tom.
Just for your awareness, that triangulation process that you were talking about has happened across those areas, but also our colleagues in Betsy Cadwell are a very strong strategic partner with Bangor University, and those issues were discussed with them at their annual commissioning board with their exec team. So we're all working together. Okay. So for the next report, that Kirsty provides, we should have a bit more information about the contract and the implications for the training programmes, which could be significant.
And we are in the process of literally our end of year survey is now being analysed. So we'll have a big piece, and we've done a lot of work on that. So
right, we'll know that so we can make sure we have time on the agenda.
It'll be a much more shall we say meaty report.
Okay, look forward to that. Thank you very much. So if there are no further questions, we're asked to note contents of the report. She gives us assurance at the moment, but clearly potential difficulties ahead. Thank you. And thank you for coming to the meeting. So I'll now move on to pharmacy. Yeah, you're doing pharmacy for us?
I am indeed, and I'll keep it very brief and just give you the updates outside of what's already in the report. With the 93% current fill rate for the 25-26, we're in contact with the 7 trainees that are due to start at the end of October. They're just in the process of going through their results release through their board of examiners within the university. So we're anticipating getting that data from the regulator soon so that we can onboard them to start, and then that will keep us up to our 99.1% fill rate then 25-26 cohort. We've got our 26-27 is currently underway, and we'll be able to report in the next quality update what the fill rate for the 26-27 programme will be, and then a couple of other bits around the
First Aid for Mental Health, which is being expanded, training for supervisors in the pre-reg pharmacy technician programme. So those sessions are running October and December, and it's building upon what we've done within the foundation training programme, which we just this week found out that we've been shortlisted for a Welsh Healthcare Award around the Mental Health Leadership Award, specifically for the work that we've done there. And I think the only other bit I'll do on the back of the discussions around training surveys is that our regulator are looking into doing national surveys for pharmacy trainees as well. So we're just waiting on the details. So we'll have another set of data that we can add to the other surveys.
That's really positive, very interesting. Thank you. Thank you very much for questions.
Yeah, I've got a couple. I mean, one is kind of on a positive in as much as on the trainee pharmacists and the attrition rate, which I know you brought to our attention last time about how this award seems somewhat different to previous years. So going from about 10% attrition to only 0.9%. And I just wondered, do we know why that might have happened? Is there something in that training that has changed that might mean that? And is there any learning for other courses or areas where we have high attrition rates that has, or is this a sort of anomaly, a one-year blip? But it just seems such a change that to be able to, it's important that we keep people on the courses and completing. So that's kind of course one, or question one. And the second one is kind of slightly the converse of that, which was looking at the numbers who've reported where they've secured positions or intended to seek employment, whether in Wales, etc. And again, in that instance, we have a kind of retention rate of 80%. So we're losing 20% to either working elsewhere or abroad. So it's kind of like the two halves of it, really. But I just wondered if there are any kind of reflections or any things that you could add to those.
Good question, Donna, and I'll do my best to answer that as brief as I can. So in terms of the attrition, this is something that we had anticipated would be less. So this training year, in light of the changes that they've made to pharmacy foundation training with the regulator, they've closed off any route into foundation other than through the national recruitment process. So previously they could secure places outside of the process in England, predominantly community pharmacy. So we anticipated this would be the case, but that's coupled with an increase in the number of undergraduates graduated from the schools and a reduction in placement across England because they are struggling to meet the new standards that they don't have a designated prescribing practitioner. So those were the two that we anticipated would impact, which has resulted in reduction in the attrition, which is what we seen this year, and I would imagine that would be carried forward into it. But to take on your point in terms of the supplying into Wales and getting the right people in, we are in the national recruitment process of England and Wales. Wales is seen as a great training experience, so we want to make sure that the people coming in are staying with us. So we have specifically targeted our recruitment drives this year just into the Welsh Schools of Pharmacy. So the numbers coming out of the Welsh Schools of Pharmacy are more than we can actually train in Wales for this year. So we have already seen an uplift in our fill rate from Wales from around 50% to I think it's closer to 70 for this year coming from the Welsh Schools of Pharmacy. So we think that will support the retention piece. And then we're working with other colleagues in post-registration for what support we are offering them to keep them to stay afterwards. So we are working on it and we'd like to see that will improve. But I think this comes back to Craig's point around the data. It's trying to actually get hold of these individuals because we get them, we can get them in the NHS, but in community pharmacy and GP practice, it's difficult to track them. So yeah, we're on the case for that.
Thank you, Laura. That's very helpful.
Very interesting. Thank you.
Just answer.
That's a question. Okay, Craig, do you want to on the data?
I feel every time data's mentioned, I can say something. No, and that's right. I suppose certainly with that new data set as well, it'd be great to work out how we get that into our ecosystem so that we can do some of that high level triangulation. But also the sort of proof in the pudding in terms of those conversions from education into employment. And they're the sorts of things again that we need to look at the survey data and then look at actually what happens year 1, year 2, year 3 downstream, year 5 downstream, which we're able already to do for GMS and are working towards the other professions once we're able to get more reliable data sets from our colleagues in shared services.
Thank you. And that's brilliant news about mental health. So congratulations on.
We have to take the outcome of those awards.
Yeah, well, the fact you've been nominated about the awards is really good news. I think, and it's such an important area as well for people with mental health. So it's great. Thank you. So no more questions. Thank you very much for the report, and we're asked to note the report. Assurance. Thank you very much. So we'll now move on to optometry. Nick.
Yeah, thank you, Chair. So the main summary of this report really is we were one short on our commissioning, so 100% fill rates except the highest certain glaucoma where we were one short. The other, we have had some feedback from the end of module enhanced process, which we're mainly reliant on for our feedback from modules. And in general, the feedback was very positive. There was one area of concern relating to independent prescribing module, and that it was too generic. As a reminder, optometrists are the regulator states you can only prescribe medications for the eye and surrounding anatomical area. So there were some questions about that some of the learnings in the modules were too broad. So we subsequently met with the university that provides the course, and they've given us assurance that they've updated the material to be far more specific to the ocular area. So there are more cases relating to that within it. So we'll watch this space to ensure we don't get the same feedback next time. But a fairly short report this time. We're just awaiting on other things, and it's quite a short turnaround from the last one.
No, that's fine. Thank you. Penny?
And no, Nick just answered my question, which was specifically around that issue about the generic nature of the training for the independent prescribing, which seemed slightly out of kilter to be teaching people about sepsis in hospital optometrists. And so I'm glad that they're going to be amending that. Do they, on that particular training, is it just the optometrists who go, or are there going to be other professions within? Is that the reason that they do it, or are they just running specific course for optometrists at that time? So I'm not making myself very clear.
No,
I need a copy. What I'm saying is, are there 6 people in the room and 2 of them are optometrists and 2 are somebody, pharmacists who haven't done the training at this stage, or is it just a module for optometrists?
It's just a module for optometrists.
Then it needs to amend, definitely.
Can I just, my question was around that. It's just a point of clarification. I suppose the students had raised some concerns. When do we see the evidence of had an impact? Do we do this annually? I mean, or is there an interim? It's annual.
So without getting into too much details, we're reliant on that survey, which is quite kind of qualitative rather than quantitative analysis. It is good because you do get that specific feedback from learners, which I think sometimes is more valuable than just straight statistics. But we're looking at how we get better statistical analysis as well from the course feedback, because there are issues in the PTES, which is the postgraduate education surveys that go out, only apply to those on MSCs and full-time. So often these are kind of part-time courses, so they're not reflected in that. So there is a little bit of work to do. We have met with Cardiff University about how to get better quantitative data out of them as well.
Sorry, Chair. Who signs off the curriculum then? What is the content of that course? Because
that's the regulator.
That's the regulator.
Yeah, so it's quality assurance. The regulator.
So it would, hopefully they'll be on the case then to say this needs to be profession specific.
Yes.
Interesting. It was signed off in the first in its current format, isn't it? Yeah. Okay. Well, we'll be monitoring that. So we see.
Yeah, thank you.
Thank you very much. No more questions. So we're asked to accept the report. the assurance and processes. So we're happy to do that. Thank you. So we now move on to the next one, which is 3.1.5. I just wonder, Ian and Martin, if you can sort of run that into the. We've got separate recommendations around this and the survey, but there is some overlap of information. So if you want to present the two somehow together.
Okay, we can do that. So,
Okay.
so I'll start with, so we've got the quality report, and this is an important one which looks back at the performance of the previous year and looks forward to the data that start to come in around fill rates, for example. That's an important component of the quality assurance report. We have got that separate report on the NSS, and we will run them together. I think that Anton mentioned the complexity of the NTS. There's a real complexity that's comparable to greater with the NSS, given that it affects all undergraduate programmes in the UK. This is an analysis of it's an initial analysis of the data. The complexity of the data set means that analysis goes on. A couple of points I want to draw your attention to in relation to this is that we've had the first scores from 2 new programmes which developed following the invitation to tender, which was released in 2020. And that's the nursing programmes at Addysg and Wrexham, which secured overall satisfaction rates in excess of 90% in Addysg and 85% in Wrexham, which is excellent. I think that there will probably be a conversation about some of the poorer results that they were received. And what I would like to draw your attention to is the fact that we have this threshold of 70% for instigating action plans, and that's jointly agreed with MEDA. However, if you take a look at the table, which is on the 3rd page of the NSS report, you'll see that we are not just taking the approach of determining whether escalations in place based on that 70 is based on sustainable improvements, and we've got a desire to achieve sustained improvements. So that's what I wanted to draw attention to. Martin can provide some more information on some details of that in relation to the quality assurance report, but then in relation to NSS, he'll be able to provide some information on what happens next in relation to how we go about managing the results and working with institutions to instigate appropriate improvements.
Thank you.
Thank you.
Thank you, Ian. Chair, to note as well that there's some brief comments in here around the Southgate East Wales nursing solution and paramedics. There's separate papers on those in closed forward, so I wasn't going to touch on them through that. Very good news about nurse, midwifery and ODP students streamlining. We've only got 6 students in escalation, and my understanding is they've now been offered jobs. So we've placed over 900 students through streamlining. This is a perpetual cycle though, because we do have in excess of 300 students graduated in March. So those conversations with health boards and shared services to make sure the right number of jobs are available are starting now and will be ongoing into the spring. The BI dashboard, which is the vacancy dashboard for allied health professionals and healthcare sciences, has been presented to the Director of Therapies and Healthcare Sciences. It's been received really, really well. Had some really good comments back from it. We're doing further work with digital to tweak that and to make it even more fit for purpose. So far, we've got 26 leaders across NHS Wales signed up to receiving that on a monthly basis, which is good news. There's a separate report on NSS, which he had alluded to. We will come back to that. I wanted to just talk about then recruitment update. The table that you've got in the report is an interim table because it's the numbers before clearing. Universities are now in clearing, where some of them will be softening their tariffs and reaching out to students and trying to recruit more. Clearing is open until after the courses commences. So most of our courses are starting now in the last 2 weeks of September. So we will have a better picture of this early October. Some concerns for us: adult nursing, mental health nursing, LD nursing, OTP, and diagnostic radiography, which adult nursing and mental health are both 74% fill rates at the moment, LD 41, ODP 84, and diagnostic radiography 93. So we are keeping particularly close eye on those professions, we know they've all gone into clearing. And just to say that you will see that some of the numbers on some of the healthcare sciences courses are quite low. That's where the health boards have requested trainees, but they are finding it difficult to release those trainees now to fill some of those places. Also to note on the recruitment figures, when you look at the commission numbers, they are just the commission numbers for September, not the whole academic year, because on some professions, particularly adult medicine, mental health, LD nurse and physio, we do have second cohorts later in the year. So it's a part year position based on what we've commissioned for September. And just to raise awareness that the Welsh Government have re-established what they call BOG, the Bursary Oversight Board, which is looking at the effectiveness of the current bursary scheme. Ian and I are will be sitting on that group. The first meeting is next week on the 16th. We're representing HIW and we're feeding updates into execs. Shared services are on it, health board representation, professional bodies, as well as Welsh Government has been chaired by the Welsh Government. So that's my update on the ECQ report. Ian, did you want to come back in on the NSS, or did you want me to just...
Actually, now I've said that, what I said before, I think maybe if we just pause, because there might be some questions which you might want to refer to the next one, but I will pause just for questions on this part. So has anybody...
Yeah, I mean, because I was just sort of trying to pull together on those two, they might cross over, Chair. So apologies, and my thinking might not be quite right. So apologies if these are in the second paper. The first one, I know that you're pulling together a report that will be going to executive review and comments on each university, highlighting best practice issues. I mean, my first thought was going to the executive review and comment. Where else is it going? Are we going to? It sounds like a board thing to me that maybe we ought to have sight of it and not just there. So that was a general one. And I think the other comes out of the other report, actually, the other two. But I don't know whether to sort of launch in now and then they could be addressed as the paper comes on.
Hold it till the next one. Okay. I've just got specific things on here, and I guess I suppose I was, because of my previous role, I was delighted to see the outcome, the results from Aberystwyth and also Wrexham, to be fair. And I just think there must be something there about what are they getting right, which might be about recruitment, the teaching and everything, which others can learn, because it's such a good result. And I've had the privilege of talking to many of those students in a past life, so I'm delighted to see that. So I just wanted to say that. I presume you are looking at what is making it.
Yeah, absolutely.
Those results.
And we visited these providers, and there's something about the way they're positioning that provider within the portfolio, the commitment to it. There's something about size, there's something about the way that they are tailoring the provision to suit the geographical location we're based in. So, Aberystwyth is a fantastic case in point that really speaks to the kind of rural location it's based in. And so it's a range of, it's challenging to actually synthesize that down to this is what the formula is to replicate. But we certainly see some really interesting practices in these areas that we think are outstanding and undoubtedly related to their success. Really close-knit teams just being established, the riding that wave of kind of enthusiasm and optimism about the provision being established. So there's a whole range of factors that are related to that. But we get really enthused about what we see happening in these areas. It's really super.
Okay, and on the other side, I just have one question about, this is the table that's on page 3 of the report. And there's a comment here to do with Bangor and the mental health nursing about an action plan and immediate intervention, and then discussion with Med. I just wondered about the timescale of immediate intervention and further intervention. Do you know what that's looking like yet?
So we met Med on Monday, and what was really, really pleasing about that is that our quality and performance framework that we have, which replicates as far as we can that of a medical deanery within within HW is really akin to the meta-targeted intervention powers document as well. So that they align really well. And we talk about immediate. I've got a meeting with the Pro VC in Bangor University at 8:30 tomorrow to talk specifically about the mental health programme and what's gone on there.
Yeah.
Because when you look at the 10 programmes we had in escalation, we saw that we are meeting monthly on, they've done quality improvement plans. 7 of them, the scores have been approved. 1 has stayed similar. 1, there's not enough numbers to generate a score this year in the NSS, and 1 has gone down. So generally, we've got really good feedback that our intervention and the quality improvement plans and the monitoring the challenge is working. Something's gone wrong in mental health, and we're looking at it.
Yeah. I suppose what I took from some of this around, because it's very stark around anger, that the diagnostic radiography has improved, and goodness me, with all the inputs and discussions, if it hadn't, it would have been very concerning. But the other improvements over time, yes, but then you've got some that have got worse.
Yeah.
Yeah.
Sorry, Chair.
No,
that
please.
was on the national student paper, and the bit I highlighted out of that report on page 3 was no improvement for 3 years.
Yeah.
And we had that conversation earlier about our expectation that something in 3 years would have been, and it kind of my other questions are specifically, the other one there is in that paper we talked about the issues at USW being unforeseen, and I think that makes me question, well, if it's unforeseen, what are our processes right, or our interrogation or whatever. That sounds terrible, that's a horrible word to use, but why did we not have anything if we're doing what we need to be doing? And then finally, it kind of to cap off that, there seems a lot for is the capacity of your team to be able to respond to all these things that are coming up at the right level to so that we can be, that you can seek assurances and progress that's needed, because obviously this is key. This is our business, isn't it?
Can I pick up on a couple of those points? I think that the question of whether the result of the USW is to be foreseen is a really important point. It's one we can reflect on. And I think that, so Mark's going to provide some information on that. I want to start off by saying that it wasn't foreseen or unforeseen. We see yo-yo results. We know there's an incredible amount of turbulence within the HE system, but we don't know what the response and the experience of individual cohorts is going to be, although we've got a range of indicators. So I am surprised it is so. I am not surprised that they are challenging results. And predicting what's going to happen year on year can be really challenging. But that is causing us to look at the sensitivity of the mechanisms we have and the fitness for purpose for actually, what would a tool look like? And what would the feedback look like that would allow us to predict with that level of granularity what's going to happen year on year?
Thank you.
Okay. Do you want to come in now, Cammy? Do you want to get the next one? Respond.
Yeah, if I could. Absolutely. So I've challenged the team around why we didn't see this coming. Some factors are there have been significant leadership changes in the University of South Wales in 2025. We meet with the students regularly. We ask them questions aligned to the duty of quality and aligned with the themes in the NSS. We meet with the PEPs and the practice supervisors and ask them similar questions pertinent to that. We collect information on attrition, fill rates, widening access, etc. The university do a self-assessment quality return to us in which we set the questions. And what I've done is I've reread, in light of the USW scores, I've reread all of those documentation, and it's very difficult in there to say this would have happened. And I've reread the other reports from other universities as well to see if University of South Wales' student feedback, PEP feedback, and returns differed significantly from it. And it didn't. What I will say, though, is that through the processes and governance that we've got in place, we know about the NSS scores. It's obviously something that's happened this year because it wasn't covered last year. We can now engage with them on an immediate basis and get them to do a quality improvement plan and monitor them against it. So I'm disappointed that we didn't pick it up, but when I've looked at everything, and we can now do targeted intervention, and it is challenging us really around the sorts of questions that we're asking the students. The other thing to say as well is we've done a lot of work led by David around speaking up safely and developing toolkits and promoting the student voice. So maybe in a way that has empowered them to speak up more this year as well. So there could be some positives through that.
Yeah, yes, that's a really good point actually, which is very positive. Okay, so on page 5 of this paper, you have the recommendations there, which I'm not going to read out. But are you content to accept those recommendations? To note them?
Yes.
Yes, thank you. So yeah, I probably wasn't right to try and run them together. So we will move on to 3.2. I know the meeting's overrunning. I apologise. I blame David because he said it shouldn't be a long meeting. Famous last words. We've had some really good conversations so far. I'm sure this will be another one. So who's going to start with this one?
So I've already brought
Anything you
points
want-
out
right.
to raise.
Okay.
There's just one
Anything
or
else?
two,
Yeah.
just one or two things for me. Just to
Sorry,
say,
sorry. Before you
Yeah.
start, I've realised I've given you the wrong recommendations on the wrong paper. So can I just go back? The previous paper, the recommendation should be, and I've lost it now, but yeah, is to note the report on the quality of Commission Education Assurance. So sorry, I was on the wrong page. So happy with that. So right, anything more in the survey?
just two things I want to bring out is through our work with MEDA and getting additional information, we can now delve down into individual questions. So a university which might have an overall satisfaction above 70, when you look at the average STEAM scores, they might be above 70, but actually one question in there may be particularly concerning. So we picked up a couple of things from universities that we wouldn't have otherwise. So we're doing some targeted intervention around that. And the other thing I wanted to say is that I'm really pleased overall with the placement scores, but the one that's causing us concern is the first placement question. I received sufficient preparatory information prior to my placement. So whilst it's above 70, it's only just above 70 on an all Wales basis, we're going to be delving down into individual programs, and we're going to be tackling that specifically with universities around how they're preparing students for their placements, because that's the one that the students seem most concerned about. So the great thing about this and working with our digital colleagues and MEDA to get this more granular information is that we can ask more pertinent questions.
And that's feeding into the action plans. So
Yeah.
we're using that to all universities to account in the reviews.
And apologies everybody that I was jumping about on the wrong paper. I've scrolled down too far. It's my questions. So I will open it out. Are there any further questions? We've sort of modelled them up, so apologies about that. I think you've answered all the ones I had about the areas. Yeah.
I just wondering,
Yeah.
you know, Martin, in seeing the questions we have placements in the student survey, it's quite limited about the administrative function of placements, and going back to the conversations we had earlier about true intelligence, about experience of how much scope in what you just said you think we have an influence in. It feels as if we're very narrow in our scope about placement experience questions as opposed to just the organisation of them. But that might be just my interpretation.
So that's an interesting observation, Tom. I think that the NSS, because of its national level, we don't have the ability to influence that. And the obvious extension of that is what opportunity we have to dig into that in more detail about mechanisms when we help. So I think that that's something that we need to consider.
Who does have the influence to change the question?
So that's at a national level. So universities UK would perhaps lobby the Office for Students. So that's at that level.
Martin, did you want to come in on that?
Yeah, no, that makes a really good question, Tom, but we do fund all of the PEFs, the practice education facilitators, out in the service, and we have a leadership role there for all of the PEFs, and we we lead that tech network, so we're quite close to it in that perspective. So whilst we've got legal influence over these 6 questions, we've got mechanisms in which we can direct
Local.
Yes.
Sorry, Chair,
yeah.
I just don't want to prolong it, but on those, though we haven't got the ability, we've fixed with those questions. Is the free text?
It's a risk.
So I was just saying, if you say I didn't receive sufficient cover, what did they want, or any comments?
You don't get free.
No, it's free text.
We don't get the free text. Universities get the free text,
Right.
and we have asked them to share it with us in the past, and they've not been forthcoming, but they've given us a bit of an overview, and it's not contractually binding for them to give us the free text, unfortunately.
What I can commit to immediately is ensuring that these themes are picked up in our meetings with students that take place in the winter contracting meetings.
Yeah, is that, you just spoke about free text, and it's not, is an opportunity to pick that up in the contracts, or would be an outlier in the universities like say, hang on, we'd have to do it with other courses.
It goes back to our quality assurance function rather than being responsible for the direct quality management. So we get free text comments for the postgraduates, and because we have that direct responsibility, that would be serious.
Right, yeah.
Isn't with the free text, if the university only gives you headline data to the theme of the issue, does that then influence the survey questions the following year that there might be? So if it is around learning resource, and it doesn't, does
The
it?
NSS changes infrequently.
Okay.
So because of the scale that it's at, and its intention to be applied across the university sector, and all undergraduate students in the final year of their programme are invited to participate. So,
okay. Right. Well, I know we have overrun, but I just think there's so much information that we've received today, and it's so critical, and it's so much part of our core reason for being. So the recommendations, which are the ones that are listed on the paper, there are 1, 2, 3, 5 recommendations for this paper, which are detailed on the first page of the report. Are you happy, again, with relation to this paper, to accept the recommendations? Thank you very much. So we're now on section 4, strategic matters, which there's none. I don't have any governance matters and nothing for information. I haven't been notified of any matters of any other business. So finally, the next meeting will be on the 13th of November. We've already highlighted some further information we'll be receiving at that meeting. And with that, if I can thank everybody here and everybody who's contributed through Teams for the meeting, and I'll now formally close the meeting in public. Thank you very much.